طيب، أهلا وسهلا وشكرا جزيلا على حضوركم معنا ومساهمتكم إن شاء الله في هذا المؤتمر الطبي العراقي للجمعية الطبية العراقية في المملكة المتحدة وأوروبا، وهنا فرعها في ويلز. I should read this to you. Welcome to our conference today. It's a premier gathering of esteemed professionals, researchers, and innovators in the field of medicine. And I mean every word of it. We are delighted to have you join us for what promises to be an inspiring and insightful event. Over the next few hours, you will have the opportunity to engage with leading experts, explore groundbreaking research, and collaborate on the latest advancements in medical science. This conference is not just a platform for sharing knowledge, but a unique opportunity to forge connections and drive the future of healthcare. So I would like to thank you all for being here and for your continued dedication to improving health outcomes worldwide. We look forward to your active participation and to the enriching discussions that will undoubtedly arise. I am Amer AlSafar, consultant physicians and lecturer to Cardiff University Medical School. I'm visiting professor to Basra University Medical School, and I chair Wales branch of the association. It is really important to know the shape of medicine, and this is the document from the Royal College. Of course, this conference has been accredited by the Royal College of Physicians, London, with 4 CPD hours, which is really very important. And this correlation or this relationship between us as a Iraqi Medical Association and the medical Royal Colleges or the Academy of Medical Royal Colleges is vital. It's really important from academic point of view. And by the way, the vice chair of the Royal College of Physicians London nowadays is an Iraqi doctor from the new generation, Dr. Mustafa Umar. And he is now, these days, he is the registrar of the Royal College of Physicians London. And we are talking about the shape of medicine and the future of workforce, the future of education and training. A lot of talk is going on about this subject in Britain because of the problems in medical workforce in UK. And it's a collaboration. That's what the Royal Colleges are asking for. Collaborative approach for better health and care. And look to this, the medical societies here. How important is the collaboration between healthcare professionals, patients, medical societies, NHS organizations, digital health, researchers, all of us to aim for improving and influencing and educating for better health and care for the patients. Because the patient safety and the patient well-being We are not only nowadays treating patients, but maintaining the well-being of the patients. And that's the medical society's role. And there are many, many medical societies, of course, in Britain. And this medicalcare.rcp.ac.uk is really very good page on the website for the Royal College as well. It's an exciting new resource hub. And I hope for our medical association to have a hub as well for lectures, for research, for paper publications, and I hope in the near future we will have an Iraqi medical journal, and we might call it International Iraqi Medical Journal, for your research and papers and case presentation, case record to be, or report to be published in such journals. So it is all very useful from academic point of view and for your position in this society and in worldwide and in Iraq as well. So medical conferences, they are here to share knowledge. We all need to share the knowledge of each other. And it is networking opportunities as well, as you can see. So attendees can build professional relationships and collaborate with peers and establish connections, of course. And the professional development, it's for us. The CPD is for you today. Globally, it's exposure to new technologies. That's the benefit of such conferences, and in attending it. It means on the global perspective, exposure to diverse healthcare practices and systems. For example, we have delegation from Iraq. They can see what the NHS in Wales and England and Scotland is doing. And that's very, very useful for Iraq system, health system. And for Iraqis who are here, our colleagues and very close to our heart, let them know that there are 6,000 Iraqi doctors in Britain, in United Kingdom, and they are all very keen, or good percentage of them, they are very keen to help Iraq and to support the system in Iraq. Welcome, Dr. Majid. Welcome. Have a seat, please. And conferences are useful for career advancements as well, because of presenting research and participation in discussions. These are very useful. I should say before I give my presentation today about the subject, this lecture theater in particular has experienced a few of our colleagues giving lectures, Iraqi doctors, and participate in discussions. And in fact, the Iraqi Medical Association in UK, we had few meetings here in this room for the executive committee years ago. And we had a meeting about 20 years ago, not far in one of the hotels in Newport City, chaired by Dr. Amer, as I remember his name, from the Iraqi Medical Association at that time, and hosted the late Iraqi diplomat. His name was Najdat Fathi Safwat. And Ustad Najdat اسم كبير في الدبلوماسية العراقية. And he was lecturing about the doctors and the diplomacy and the correlation between all these issues between diplomats and doctors treating leaders. It was very interesting lecture. So we have history with the Newport and with Cardiff in South Wales. Having said that, as I have been working in South Wales, in Cardiff and in Newport for the last 25 years. My specialty is in stroke. I'm a geriatrician, I am. But part of the geriatrician duties, part of it is looking after stroke patients here in Wales. Neurologists and geriatricians are looking after stroke patients in England. I don't know about the situation in Iraq. And we are always today, when we talk about our subjects, Iraq and the health system in Arab countries is in our mind as well. So I have no interest, no conflict of interest to declare today, and this is the new building for our hospital. the new hospital in the Grange Hospital, which is few miles away from here, and the hyperacute stroke unit is based in this building. The brain, as we all know, is a complex organ that controls thought, memory, emotions, touch, motor skills, vision, breathing, temperature, hunger, every process that regulates our body. So you can imagine the dead brain cell due to stroke, what will happen to all these activities in human brain. And nowadays, I don't know why, but there is an interest nowadays in the academia worldwide in brain research. And let me say neuroscience research. This is National Geography this month, only a few days ago. I read it. It's all about the brain. And discover the ways your mind works. 40 pages of articles and research about the issue. This is the lady, the broadcaster from the BBC Click program, and with a special edition about the brain and the aging brain, how to prevent aging, and how to keep active brain activities, and the mental illnesses, and dementia, and Alzheimer's disease. What are the new research and the new treatment, the new approach for such issues? BBC in depth, talking about can we change how our brains age? So it's a lot of interest and discussion. And of course, my references, I'll go to Stroke Journal every month, Lancet in Neurology and Stroke Research. This is another. And these are many, many books about stroke. You can see it in the in medical libraries, talking about different issues of stroke care. But we always say time is heart, time is a brain nowadays, because of the presentations of the symptoms and signs of stroke, and how quick is the patient reaction and the doctor reaction to treat these signs and symptoms, to treat the cause originally. So time is a brain nowadays, because there is a treatment. There is a treatment to prevent further complications of stroke following the brain clot in one of the brain arteries. And this is a new book about thrombectomy. So it's not only thrombolizing the stroke patient and the clot, but in fact you take it out, thrombectomy. And this is now a book about the subject. Clinically speaking, stroke is an ischemic event, 85% ischemic events, defined as an episode of neurological dysfunction caused by focal, cerebral, spinal, or retinal cell death due to infarction following vascular occlusion or stenosis. And the magic word here is the vascular, because this dysfunction, and this is up-to-date definition by the Royal College of Physicians. And you can see that there is no 24 hours time. So there is, of course, if it happens only for a few minutes, this dysfunction up to 24 hours, this might be due to TIA, transient ischemic attack, rather than a stroke. But all due to vascular reason, arteries or veins. And this is the TIA, or transient neurological dysfunction, due to focal brain, spinal cord, or retinal ischemia without acute infarction. So this is transient. That's the way TIA should be looked at urgently, diagnosed, and treated. And this is just illustration of the atherosclerotic blood vessel, from where clot is coming, why clot is happening. Stroke disease is elderly patient's disease. It's very common for us. It's common disease in elderly, but it doesn't mean that it is not happening in young patients. And there are chapters nowadays in stroke books about stroke in the young, and even stroke in children, and the treatment remains the same. Thomas Wallace, we all know this name, and Circle of Wallace, He is the English physician, and I always think about circle of Willis and, of course, the vascular supply of the brain with the blood, and it is very complicated. We know and we classify stroke according to the vascular origin and the vascular cause of it, whether it is anterior circulation, posterior, or partial anterior, or occipital. And this is what I meant by the occipital, for example, and the spinal, anterior spinal arteries. So it's good to know the anatomy in details of the neuroanatomy or the brain anatomy. This slide will give you what I said, about 85% of strokes are ischemic and 15% only are hemorrhagic. SAH stands for subacute, or stand for subarachnoid hemorrhage and intracerebral hemorrhage. It is subarachnoidal part, anatomically speaking, or inside the tissue of the brain. Intracerebral hemorrhage it can be. Ischemic can be cardioembolic because of atrial fibrillation. Irregular heartbeats can then disseminate clot to the brain and can cause brain ischemia and can cause stroke. And that's why we go to the origin. Why he had a stroke, why X man had a stroke, why the other patient had a different cause of strokes, by further exploring the causes and investigating the causes of stroke. Lacunar type of stroke, very focal, very small, or large vessel disease stroke. And in spite of all your investigations, you might end up with no cause behind the stroke, and you should accept that. So it is the third commonest cause of death. I should say 500 to 700 cases in a community of 100,000. If you look at the global burden of stroke and you go to Iraq, you will see a figure of 200 to 300 cases per 100,000 people in Iraq had a stroke. 200. But I don't think, if in Britain 500, how in Iraq 200? So we need to make sure that our figures in Iraq are accurate figures. And I should say, if these are right, in Britain it is right, then we should have 2,000 stroke cases a year in Cardiff, based on the population of Cardiff. And we should have 18,000 cases of stroke a year in Baghdad. 18,000. 18,000 stroke patients in Baghdad a year, if it is based on 500. Of course, if it is less than 200 and based on the population of Baghdad, which is 9 million at the moment. I welcome Dr. Mohammed Al-Sudani, the chair of the Iraqi Medical Association. Thank you for coming. Dr. Mohammed Al-Saadi, our member of the executive committee, and Dr. Mazen Sirsem. You are all welcome, and all others, of course. And it is multidisciplinary team care for the stroke patients, start from the nurses and doctors and allied health professionals. But I put this is the Journal of Royal College of Physicians, the Clinical Medicine Journal, because of the disparities, ethnic disparities. There are few patients who are colored or black and ethnic minority patients in our research in stroke in Britain. And I don't think that's right. We should have more research about Iraqis in Britain. How many of them had a stroke and why? We don't have such research. So one of the roles of this association is to initiate such activities. Because this paper, for example, recognizing that there is a problem and giving this example about COVID-19 clinical neuroscience study, this study. So ethnic disparities in neurological research is a major issue in Britain, and we should work with the Royal Colleges to correct that. Human burden of stroke: 35% of people who suffer a stroke will be left disabled, need rehabilitation. Play the role of third. Third of stroke patients will die, third will be disabled, third will be will improve. And we always say these are Cincinnati pre-hospital stroke scale. Nowadays in medicine in Britain, we have scales for everything. Objectively measuring weaknesses, objectively following the patients up until the well-being with modified Rankin scale or score. So scoring system. And with this we have face, and we put test faster. So we put face because of the drooping of the face in stroke, arms, weaknesses or drifts, S for stability or speech, and talking is the T for talking in this. Eyes, difficulty in seeing out, and immediately react to 999 if these are face droop or one of these organs affected, or arm drifting or weakness for whatever is the period. And there are risk factors for stroke. One of the top risk factors for stroke is hypertension. Hypertension. How many of our patients whom we are treating for hypertension are in fact maximally treated for hypertension? Are we treating hypertension in a way that is satisfactory to us before being satisfactory to the patient? Atrial fibrillation, cardiac diseases with valvular abnormalities, hyperlipidemia. So these are part of the investigations of the patients. At the first minute when we see the patients in emergency room here in this hospital, diabetes, carotid artery stenosis, and transient ischemic attack. Of course, behavior, cigarette smoking, alcohol abuse, low physical inactivity, and the diet. And this is the type of carotid duplex that we do for the carotid stenosis, because there is a treatment, and carotid end arterectomy, and that is what Ustad Mundir Duri, one of the vascular surgeons in Britain, in Leeds, he done. This is before, this is with occlusion of the carotid artery, and this is after the carotid end arterectomy, and kindly he sent me this photo from his papers. So we have, I should say, it is a preventable. Prevention better than a cure. If this slogan is right, it will be first right in stroke and cardiovascular diseases, cerebrovascular diseases or cerebrovascular syndrome, and cardiovascular diseases. So these are the main advice, of course. We all advise our patients about the issues related to lifestyle of the patients. And many years I've been talking to communities, and this is Stroke Association in Wales. And we engage. So our association, Iraqi Medical Association, engage with other associations. That's one part. Engage with Royal Colleges from the other part. So we have a big role to play if we are really have the time, dedication, and enthusiasm to play that role. And the British academic institutions, they are listening. They are really desperate for us to speak to them. And the media have a role. This lady, Nadia Hussain, talking about sugar tax. This guy, midlife health test, and every day in British media you see something about health and health advice. And we have national clinical guidelines for stroke. This is now the 5th edition. Started 2000. And now 2023 edition, and detailing the care for stroke patients and TIA patients. And from the first minute they come through emergency room to the discharge of the patient's home. So it's really very good clinical guidelines. about 300 pages. A very good read. And I read it for you. We might summarize this as well. These are clinical guidelines. So any person with fully resolved acute onset neurological syndrome that might be due to cerebrovascular disease need a specialist assessment. Specialist. Not the GP, not the general practitioner, not the family doctor. Specialist. Why? Because we should evaluate and we should assess and we should investigate the cause. Diagnosis first, make sure that it is stroke, because there are mimics to stroke, and determine whether the cause is vascular. That's important. These are the mimics, you see. So you need a specialist, you need an experienced physician to say this is stroke. This is stroke because of the taking history quickly. Maybe the stroke patient is unable to speak, taking history, parallel history from the family, and do examination, do CT scan within the first hour to make sure that it is not a bleed, because we said that it is ischemia or a bleed. And these are the mimics: hyperglycemia, hypoglycemia, encephalopathy, infections might be, neurology might be, seizure maybe due to epilepsy or drug toxicity. So there are many other reasons for what looks like stroke. And this is a new paper. Look, talking about diagnostic challenges of focal neurological deficit during an acute stroke. Is this vascular? This is a new paper. This is a new paper and published in New England Journal of Medicine. So even nowadays we are talking about this because we have issues. That's why. What is nice in NHS system, in spite of all our reservations about the NHS, is when there are issues, the brilliant doctors put a plan for a drug trial, put a plan for solutions to this issue based on research, based on thinking deeply why we had this. So what we have, what led to this paper? Because we misdiagnosed stroke and we put the patient to thrombolize that patient, and the patient had bleeding and death. And initially the diagnosis was wrong. So how you allow physician associate to deal with stroke patients? You can't. You need physician, you need experienced physician to deal with stroke patients. You see, so that's really very important because of the aftermath of the complications and the consequences of the treatment of stroke. So that's a clinical assessment. Should be given aspirin, of course, if you are sure that this is patients with focal neurology due to a case of vascular origin and completely resolved within 24 hours, give aspirin 300 immediately unless contraindicated, and assess urgently within 24 hours by stroke specialist clinician as well. TIA management should be assessed again by stroke specialist, and again you need the CT brain, so except when hemorrhage requires exclusion in patients taking anticoagulation. Patients on warfarin, for example, I need definitely to exclude a brain hemorrhage by CT brain. For patients with suspected TIA, nowadays we do MRI. This is in the clinical guidelines I'm talking about now. MRI should be the principal brain imaging modality for detecting the presence and or distribution of a brain ischemia. Ensure that all patients with suspected TIA are assessed and diagnosed urgently 7 days a week. So we have TIA clinic here in this place, 7 days a week for TIA patients assessment. Make sure that it is TIA. Margaret Thatcher had few TIAs. I saw her in 1991, 92 on the platform on the Commons, and she lost consciousness for less than a minute. Her became slurred speech, and she died because of complications of vascular dementia. Churchill had TIAs and stroke. All these presidents of America, they had cerebrovascular diseases, which led to dementia and to complications of stroke. So who want to be president of USA with all these hassles and stresses? Secondary prevention of stroke. What I mean, if you had a stroke first time, God forbid, then how I prevent you from having another stroke. That's what secondary prevention. So every stroke patients in Britain, we follow them. We follow them up at least every 6 months, and then every year, and then we keep following them, and then we refer them to the GP to follow the primary care doctors. So reperfusion, this is what I meant by thrombolizing stroke patients. So reperfusion, so patients, I'll give them immediately, if they present to me within 4.5 hours of their signs and symptoms of stroke. And I convinced myself clinically and by CT brain scan that this is a stroke, ischemia, I thrombolize with TPA, tissue plasminogen activator. Nowadays, there are research more than 4.5 hours, because 4.5 hours is not enough, maybe for some patients. So they extended with different types of tissue plasminogen activator. Thrombolysis with alteplase is now administered to between 10 and 11% of patients with acute stroke in UK. 10 and 11%? Very low, very low. We should aim for 20%. This is what we are doing here, 10 to 11%. Because people, they have this stroke at home, they don't realize it is a stroke. One of the GPs, he came home from work, and he put his hand in his pocket, pick up the key for the door, to enter the door, and he couldn't open the door. He couldn't turn the key for a minute. This is a TIA. This GP went to his colleague and he referred him to the hospital. There are many, many stories that I can tell you from my own, let alone my other colleagues. We have 7 stroke physicians here in this hospital, in this health board. And this is what I mean. This is a new research from New England Journal of Medicine only last week. Retiliplase versus alteplase. So new thrombolizing agents all the time. And look at this conclusion. In patients with acute ischemic stroke who were eligible for intravenous thrombolysis within 4.5 hours, after the onset of symptoms, retiliplase was more likely to result in an excellent functional outcome. That's what we are looking for than alteplase. So always medicine and the drug companies, it is in their interest at the end to develop and improve the medicines for different specialties in medicine. Taking the risk? Yes, of course, patients need to take the risk because there are complications following the thrombolizing. I always need consenting. I ask my junior colleague or trainee doctor to consent the patient for having a thrombolizing agent because there are complications. So there is always in life, we always take risk at one stage or in different, every day we take risk with decisions. So with this as well, if anybody presented to A&E department with what is a query stroke, you should take the risk and take the thrombolizing agent because there is a huge implication on the functional outcome of stroke if this patient is thrombolized. And in fact, if a major blood vessel is occluded because of what I can see on the CT scan and CT angiogram or MRI angiogram, then I should refer to Bristol. Unfortunately, we don't have in Wales interventionist radiologist to do the thrombectomy. So I thrombolize the patient, refer to Bristol over the bridge to do the thrombectomy, and we should choose very carefully patients for thrombectomy. I know the practice in Iraq, and unfortunately I have stories from my colleague, Dr. Osama Shukr Muhammad Amin, who is a stroke physician. He's an excellent stroke physician in Erbil. And he was telling me stories about thrombectomy in Iraq. Difficult. Not every patient for thrombectomy. They do it first time. Thrombectomy for patients. And that's not the right procedure at all because it ends up with complications and you lose the patient. So that's the benefit of this collaboration between us. We explain why you are going for thrombectomy. Why you don't follow the guidelines and the protocol? And we have a protocol. And now for ischemic stroke, dual antiplatelet treatment up to 72 hours as well. If the patient is eligible to thrombolyze because of the 4.5 hours of his presentation time-wise, then I thrombolyze. If not, if he came to me after the 4.5 hours, then I will do antiplatelet, aspirin, clopidogrel. This paper is amazing paper. Among patients with mild ischemic stroke or high-risk TIA of presumed atherosclerotic cause, combined clopidogrel and aspirin therapy initiated less than 72 hours, then after symptoms onset led to a lower risk of a new stroke than aspirin therapy on its own. You see research? It's very, very nice coming on with all these papers and very useful. So if you are a patient and the GP or the hospital doctor does not start you on aspirin and the clopidogrel together, and you had another stroke 2 months or 3 months after, you sue the doctor. You say, look, why you didn't give me this? So it's very important, the knowledge, the public knowledge about what's going on in the field of medicine. And this, by the way, these guidelines are all open in the public domain. Everybody can read these guidelines. So I told you about thrombolysis, but you need the blood. Of course, these are part of the complications. Doctors-wise, they know I cannot thrombolyze patient with blood pressure of 185 over 110 in A&E because there is a risk of a bleed. So what I do, I give that patient labetalol. I need to decrease the blood pressure as quickly as possible because I have a time window of 4.5. Time is a brain. Neurons are dying. So I should intervene as soon as possible. And these are contraindications to thrombolysis as well. I think I will end here. I have just this is about intracerebral hemorrhage, of course. As I said, 15% of cases, about 11% of all patients presenting to hospital in UK and Ireland with acute stroke have intracerebral hemorrhage. This is in UK. I don't know about Iraq. What is the situation of brain hemorrhage in Iraq? And what are the main reasons? The main cause of the brain hemorrhage in Britain is hypertension, uncontrolled hypertension. I done an audit with 20 years ago with one of the neurologists, Mr. Wiles, in Heath Hospital, of whom I took a friend, Iraqi friend, because of MS. And Prof. Wiles, he said, "Are you from Iraq?" I said, "Yes." He said, "I'm afraid I'm seeing MS from Iraqi patients more than before." He retired now. But I was doing the audit about the brain hemorrhage in Wales. Brain hemorrhage in Wales. HAZU stands for hyperacute stroke unit. We use this term because you cannot care for the patients in a general medical unit. Good hospital, good stroke care, any country. If you visit any country in the world, oh, my stroke care is excellent. You ask, do you have a stroke unit? If they say yes, then that's fine. You have a hyperacute stroke unit. If they say yes, excellent. But if they say no, then they can't classify their stroke service as good at all because of all this. You see, there are studies, Lancet, stroke units around the world. The success story continues. What are the components of effective stroke unit care? FRCP recommendations, all been done in stroke care unit. You thrombolyze in A&E, but you transfer patient to stroke unit. You might thrombolyze in hyperacute stroke unit because very skillful nurses, very skillful doctors, very skillful neuroimaging, and the skillful physiotherapist and occupational therapist. So that's what you need. And this is the book, Stroke Units, Stroke Unit Care for Patients. And this is the team, multidisciplinary team, looking after stroke patients. You see, so that's really important. This slide is showing stroke unit, medical unit. You see, 78 will become independent if they are treated in stroke unit, and so on and so forth with stroke research. This is how to set up. I give this slide to my colleagues in Iraq. I participated in Amer Medical Medical Conference 2 years ago, virtual, and in Basra Medical School. I gave many lectures, and one of them is how to set up a Basra stroke unit, how to set up Baghdad stroke unit, how to set up Amer stroke. How many stroke units we need in Baghdad? 18,000 stroke patients a year in Baghdad only. So you guess how many stroke units you need. So a huge task. And this is about the audit of our service by the Royal College of Physicians London. Not only our service here in Wales, but all over the country. Any hospital with stroke unit been audited by the Royal College of Physicians, and this is really important. Thank you so much, and quite happy to answer a few questions. Thank you. Yes, please.
Thank you.
Dr. Majid Al-Khatib, pediatrician.
Yes. So we are the opposite side, me and Mazen and many other folks. Well, thank you very much for this. You're absolutely right. It is not the guidelines and protocols when you follow give you the best outcome. Yeah. It is the centers of high expertise. Absolutely, that's everywhere, including in our, area like congenital heart disease, heart thing. Now it's the larger centers with expertise. But one point about comment on the statistics, which modern Iraq post-war lacks among many other standards, of course. It is, you're right, there may well be more larger incidents, actually, than 200 per.
Yes, per 100,000.
500 in UK. Yeah. But it is very well known that regional and international variations in many diseases, the differences.
Yes.
And I remember, and I'm sure my good friend and colleague Mazen with a long experience, remember the ISAC study, the international study of allergy and asthma in childhood, where it showed that in UK or Western countries, up to 1 in 5 you can get asthmatic. Where in third world countries, where lots, that's because of the hygiene theory.
Yes.
When you have cleanness and immunization and things and everything, then you get the Th2 stimulation and you get more allergies and asthma. Where there's dirt and things and mixture and with animals, you'll get less asthma.
Yes.
And allergies. And that's very well known. But of course, in Iraq, it's up to the right. One thing, the third slide, which says brain, it's spelled as Bri-I-N, and I thought this was written by a stroke patient.
Well done. Thank you for this one. Now, you reminded me by Majid Al-Shamma, the pathologist. I was third-year medical student, and he was talking about asthma. And he said, do you know why we have a huge number of patients with asthmatic patients in Baghdad? And he said, because of ghubar, هذا التراب, Majid al-Shamma and how he teach. And do you know why it is in Britain very high? Asthma is very high? Because of رحيق الزهور. وريحة الزهور.
مجيد الشماع لو أحمد الشماع.
أحمد pathologist. أكو مجيد الشماع صحيح. أحمد الشماع. درسني في صف ثالث. 1977. نعم. بارك الله بكم. شكرا. نعم. We have 1 minute. Yes.
Thank you for this presentation. About the situation of both stroke, thrombus, and bleeding.
Yes.
How can I control? How can I redirect the physician? Because this is important.
Yeah, of course.
One opposite the other.
Yeah. Well, clinically speaking, you can differentiate intracerebral hemorrhage or brain ischemia, but it's unreliable. CT scan. You take for the patient. I push the trolleys of patients to the CT room, which is nearby the examination room and emergency room in the hospital. And that's the way to differentiate.
I mean the treatment, therapeutic, because one opposite the other.
Well, yeah, the treatment for ischemia, I'll give it thrombolizing. And if it is intracerebral,
Both, which is present.
yeah, intracerebral hemorrhage is a different type of approach. If I can prove that this is intracerebral hemorrhage, and it's easy by CT brain scan. You can see it very well. Thank you very much. Yeah, yes.
Do you agree with Ahmed al-Shamma theory of maximum Britain caused by
Well, he was making a point.
No, I don't think we have too much expectation of Britain.
Yeah, because allergy, I think, and hay fever.
In Britain, they used to use they burn a lot of coal.
Yes.
Very
Oh, yes.
smoky towns. And if you look at the wall, they're all smoke.
Yes.
And that's the cause of that.
That's one of them.
Britain, not the
Yeah. Yeah. He has his own way. Allah yarhamah. طيب. شكرا جزيلا. Yeah. شكرا جزيلا. The next speaker is Dr. Ali Mahdi. Dr. Ali, he graduated from Cardiff Medical School, Cardiff University, 2003-2008. He had a bachelor in pharmaceutical science, 2000 to 2003. He is consultant hematologist in this health board since 2018. And he had locum consultant hematologist all over Wales, and including Singleton Hospital in Swansea. Ali has a huge experience in clinical trials, and he had very good fun, the clinical trials wise. So his involvement in a trial setup, assessment of a trial eligibility, obtaining consent, providing medical care, adverse event reporting and casualty assessment, so on and so forth. He had previous studies acting as a principal investigator. One of them is an efficacy and safety study of prashinostat in combination, yes, with as it is need in adults with acute myeloid leukemia. Amazing. So here we are. Ali, you are talking to us today about hematological emergencies, diagnoses not to miss for any medic.
Thank you, and welcome everyone. I have to apologise because we don't have any hot water for tea and coffee, which is a major problem. So hopefully we'll try and sort that problem out. And I've known Dr. Amer, who I've known for many years as a close family friend. Everyone's first for participating in really. So
we are recording our lectures today, so that's why the camera.
my main clinical interests are myeloid malignancies.